Yakima Valley Community College Radiologic Sciences Program presents Radiographic Positioning. Lower leg.
Our demonstration for today will be of the lower leg, often called a tib fib. And we've got Jacqueline back on the table. And again, no shoes, no socks, the pants rolled up. We have a 14 by 17 cassette. Some departments have extremity 14 bys, others do not. So you will need to know what the protocol of your particular department is. I do have a right marker, and our patient does have lead for her reproductive organs. Okay? The distance will be 40 to the tabletop, but some rooms we may need to increase the SID. I'll demonstrate that in a minute when we actually get into the procedure. It's to allow more of the divergence of the beam so you can get a larger field to cover a film that runs catty corner. The tib fib tends to be a fairly long bone, and you need to include both joints. And if you try to do the tib fib in this relationship, where the collimator reaches the 17 inches but not much beyond 17, you may clip a joint. And I think you can see here that with the divergence of the beam, her knee would be projected right off. So we're going to have to do her catty corner or go from opposite corners. I'm going to turn the cassette. The ID blocker, it doesn't really matter where you put it as long as it doesn't run from the knee to the ankle. So it could be here or it could be flipped up over there. You're going to take one on one cassette and the lateral on the other cassette. Just make sure the ID blocker stays in the same relationship that you picked in your very first setup. Keeping your collimated field, your marker placement, your ID blocker placement, those are all aesthetic qualities. If you can maintain them, your product is prettier. You've colored within the lines. In other words, your drawing isn't sloppy. You're coloring within your lines. Okay? So we're going to start. We need to ask our patient where their injury is at. Where do you hurt today?
Up here.
You hurt up here. That's closer to the knee joint. She actually has a little mark on her leg there. In the field, you would not necessarily have to ask where the pain is. You're going to see bruising, you're going to see bleeding, you're going to see swelling, and you'll know. But if you don't know, do ask your patient, because that will become the joint of interest. Okay, if she told me her owie was down here, I would focus on the ankle. And my AP, I would make sure it's a true AP ankle and a true lateral of the ankle. With her having a proximal injury, I'm going to focus on the knee, making sure that the knee is in a true AP position or the knee is in a true lateral position. Many times the leg is bowed, and a good AP of the knee will not be a good AP of the ankle. You can't get both of the joints to be that ideal AP or that ideal lateral position. So focus on the area closest to your injury site. If it's mid-shaft, go for the knee. Always go proximal if the injury is actually mid-shaft. Part film reference point is the joint of interest should be 2 inches from the film's edge. You want that 2-inch clearance because the divergence of the X-ray photon beam will actually throw that joint further, and you want to have enough clearance on your film to where when it does get thrown that you do not miss any of the pertinent anatomy, including the entire joint on there. If a leg is shorter, I would just center the leg. I would make sure that the distance from the film's edge and the ankle is the same as the film's edge in the knee. So we're going to do a proximal here first, and I'm going to find the patella. I'm not pinching, but I'm outlining the patella. And the knee joint, there's the apex of the patella. The knee joint is 1/2 inch distal to that point. Here's the patella, and the joint is 1/2 inch distal, 1/2 inch below the apex of the patella. So there's my joint space, there's my film's edge. You can see I have more than the 2 inches, so I'm going to slide the cassette down. Okay. And I got the point of the cassette right underneath the femur and the point of the cassette right underneath the center of the foot. Find the joint, look at my film's edge, come down here, find the ankle joint, and I've got more than 2 inches on both of her joints, so I'm just going to center her leg in today's instance. And, okay, joint space, assess your film's edge, joint space, assess your film's edge, and our leg is centered. Both joints have plenty of clearance, 2-inch clearance on both sides, so I'm happy with the centering now. Okay. If by chance you have a basketball player that comes in and they're close to 7 feet, you may have to do this on 2 different cassettes because the tib-fib may be so long it will not fit even catty corner. If you do both cassettes, make sure there's some overlap in the center. Include the ankle on one, include the knee on the other. Okay, so we've got the leg centered. I'm happy with the clearance. And now I get my tube centered to her leg. And I know it's centered by the amount of light on the tabletop. I think the camera might be able to see this space here matching that space there. Let's give the camera a second to get focused on that. Equal light on both sides of the cassette will indicate that the central ray is to the center of that unit. Okay. Also notice, I think you're focused right here. See how I have shadow coming across the corner of that cassette? This is an example of where I may want to increase my SID off of the standard 40 inches. Watch what I'm going to do. The camera doesn't have to move with me. I'm going to raise the tube. I want you focused right here. I'm going to raise the tube and see what happens to the collimated light. See how I gain a little bit more distance. Again, collimators may not go past the normal 14 inches or 17 inches. I need more length. My only option is to elevate the tube or lower the table, and this particular X-ray unit will not lower, so I must elevate my tube to get better clearance there. On Jacqueline, it wouldn't have been necessary for me to do that because her lower leg, remember, I had about 3-inch clearance on both sides. But somebody with a longer bone, if you only had that 2-inch clearance, you would elevate the SID in order to gain a little bit more collimated field. I've got the leg coming down the center of the collimated field, and I've got fairly tight light. Don't have a collimated field like that. You're over-radiating the patient. Bring the edges in to the size of the leg you are looking at. Okay? And I'll refresh your memory. We are doing a proximal tib-fib. I'm going to focus on the knee, and a true AP knee will have the patella slightly medial. If the camera can focus on my fingers here, what I'm looking at is the distance from the lateral border of the patella to the leg, and the medial border of the patella to the edge of the leg. And I want this side to be a little wider than this side, because I want the patella off midline slightly towards the medial aspect. That will place the knee in a very nice AP position. I will attempt to flex the foot, and her foot is slightly turned in rather than being straight up. I can live with that very, very easily because I'm focused on the knee. I have the patella slightly medial, and most patients the foot would not be totally straight up if the knee is in a true AP position. I need to put a right marker on there, and I'm going to put it to a lateral corner just inside the field, and I will be able to make my exposure now. Let me just recap. I've gone corner to corner, so I gain length, and on this particular patient, I'm able to center her leg. I want at least 2-inch 2 inches from the knee joint, which is 1/2 inch below the apex of the patella, and I want 2 inches from the ankle joint, which is at the level of the tibial-malleolar line and slightly above the fibula here. I want the patella lying slightly medial, foot flexed, tight collimation, and an arm marker on there in an anatomical position. And I may make the exposure, rotor zap. Okay? You need to change cassettes. So a patient will lift her leg up. We'll get another cassette. I'm going to put the ID blocker back in the same position that it was. I'm going to have my R marker in the same position that it was. Before I do that, I'm going to get my patient in the lateral position. Again, the patient might be more comfortable lying down or sitting up. I think our patient has told us she's going to be more comfortable when she's lying down. This leg can be rested back, or it can come up and over. Are you comfortable with the leg right there? Okay. Okay, now, again, we need to center the leg. Here's the tibial-malleolar line, and the ankle joint will be right basically at the same level as the tibial side. And at the knee, here's the crease of the knee, and I'm going to think about the relationship of the tibia with the crease. And the tibia with the crease line, if I look at it in a T position or perpendicular position, it's this intersect line here that shows me where the knee joint is at. So there's the knee joint, and see how I'm looking at the film's edge to see if I have the clearance. And there's the ankle, and I see that I have the clearance, and I'm going to move the cassette up just a little bit to balance that leg. Okay. The knee is slightly bent 20 to 30 degrees. This example, we could have her knee bent a little bit more, but I'm satisfied with this. And now, since it's a knee focus, proximal focus, I'm going to determine if she's in a true lateral position for the knee. I want the patella, the 2 lateral edges, one right on top of the other, superimposed. Okay? We've got the 2 edges of the patella, and I think the camera can see this. If they're not superimposed, I don't want you handling the knee here. I do not want you manhandling that knee. Look what happens if I just roll this leg back or forward, upper hip back or forward. And I can just tell the patient, can you roll back? Can you roll forward? Okay? Talk more, touch less, or at least do not touch the part that hurts, because they can roll. Can you move your hip back? Can you move your hip forward? And probably right there to get the patella edges, one right on top of the other. Foot can be flexed, and the leg needs to come right down there. I'm going to have to turn my cassette a little bit because it's not quite fitting. And the right marker will go back where it was to match the first one. Okay, the point of the cassette, center the leg. Point of the cassette, center with that leg. Tight collimation. The calf of the leg, the light is just barely clearing the calf of the leg here. You're seeing more light in the front, but I have the calf here. Crosshair coming right down the center of the leg. Okay. Okay. And then you can make your exposure. Okay, we're going to let the patient relax. And we'll review the criteria for a proximal tib and fib. You take 2 projections on 14 by 17s. Most of the time you go catty corner in order to gain the length. Sometimes you have to take 2 films. If the patient's close to 7 feet tall, catty corner, you will not get both joints on there. And what if it's a child? What if it's a 6-year-old? You could actually put 2 projections on 114 by. You'd put one on this half and one on this half if the leg is short enough. Put the ID blocker away from the joint of interest if you're going to do 2-on-1. The average adult, you need to do 1-on-1. From a corner-to-corner relationship, you take an AP and you take a lateral. You focus on the joint that's nearest the injury. In today's lesson, we focused on the knee because of our proximal injury, and an AP will demonstrate the patella to be slightly medial, slightly towards the tibial side. And in a lateral relationship, the patella will be superimposed, the lateral edges. You will know it's superimposed if the patella is free of superimposition from the femoral condyles. If there's density, if there's space between the femoral condyles and the patella, you have produced a very nice lateral proximal tib-fib. Now, an ankle, if it's a distal injury, the positioning will be exactly the same, so I'm not going to review the positioning. Center the leg, at least have 2 inches on the joint of interest side, include both joints, and you would focus on the ankle. And if you'll remember from previous lesson, a true AP ankle, the foot will be straight up in the air. Let's just kind of mock it, Jacqueline. Foot straight up in the air. I'm now focused on the ankle joint. I'm not going to worry about the knee. I want the foot straight up in the air. And if I've done a good job, the fibula will be slightly superimposed over the tibia and the talus. In the lateral position, again, you would position everything the same, but you'd focus on the ankle and you would superimpose the malleoli. And usually that is about a 15-degree displacement of the foot up off the cassette. And that would superimpose the malleoli. Can you think of anything for a tib-fib? Tib-fib might be called lower leg or a tib-fib. And that will close for now.